Potential Not Pathology, embracing creative and resourceful approaches to psychotherapy with author and therapist Dr. Paul J. Leslie.
Welcome to Potential Not Pathology, where we offer information and inspiration for mental health therapists who are interested in learning and applying unique therapeutic techniques and concepts into their work. With a focus on the potential each client brings to his or her therapy session, this program examines ideas and tools which can assist your clients on their journey toward healing. I'm Paul J. Leslie. I'm glad you're here. Today we're going to be listening to an interview I did with Dr. Bob Bertolino. Bob's a great guy. I've had the privilege of spending some time with him at conferences, and I always value his insight. He's a professor of counseling at Maryville University in St. Louis, Missouri. And he's also a senior clinical advisor at the Youth in Need community-based nonprofit organization in eastern Missouri that serves children, youth, and families. In addition to that, he's also a senior associate for the International Center for Clinical Excellence. And he's going to talk a little bit about such areas as feedback-informed treatment, the program he's been working at, Youth in Need, the importance of expectancy and hope, and a strengths-based approach to working with young people, old people, families, and working in a systemic nature. I value his input. He has taught over 500 workshops throughout the United States and over 10 other countries, and worked with multiple national, state, and local organizations in the intent of applying these important concepts of focusing on strengths when working with people and focusing less on pathology. His website is www.bobbertolino.com. That's www.bobbertolino.com. And so I hope you enjoy this engaging interview we had. Dr. Bob Bertolino, welcome to Potential Not Pathology.
Thank you, Paul.
All right. Now, could you let everyone know who might not have read your excellent books and gone to your trainings, kind of how you came to become a therapist?
Well, I started, went to school to play baseball, and that didn't work out after some arm injuries. So I had to sort of pick a direction. And I got an undergraduate degree in social work and started working in the field pretty immediately, working in a residential program for teenage youth, ages 10 to 18, and, working long shifts and, kids who are in crisis and, homeless and so on. And then from there, I realized that I really wanted to do more clinical work beyond frontline work, which I did enjoy. So I got a master's degree in counseling, and then I went on and got my doctorate in marriage and family therapy. And I chose marriage and family therapy because I was really interested in working with families. So I kind of started in the field and stayed in the field, I guess you could say.
Yeah. So when you had this inclination to work with families, what do you think motivated you to kind of pursue that path?
Well, it sounds a little cliche, I think, but my family itself is a large family. I have 6 brothers and sisters, and so I learned a lot about how you go about sorting things out, and also faced the challenges of my mother being a single parent, and so I felt like I could relate in that way, but I also was really interested in how important it is to facilitate systemic change. So, whenever possible, the possibility of working with multiple family members or a system that I could help strengthen was very appealing to me. And I thought, if I had that opportunity, I'd like to pursue it because, so many of these kids, again, come from homes that are fragmented or fractured in some way. And I thought that I'd be much more successful if I could intervene by, strengthening the families, again, when possible.
Yeah. You brought up the term systemic. I kind of just wanted your take on this. I have noticed over the last few years the nature of what people are referring to as systemic therapy or even systemic family therapy has seemed to have changed a little bit. I can remember way back when it was more focused on things like they included everything from like Minuchin structural aspects, Haley strategic, working with a system. Now there seems to be a little more narrative and interpretation involved. Do you find that working systemically from your perspective is a little different now than maybe it used to be? Or are you kind of more adhering to more, I guess the term, older ideas about systemic interaction?
Well, much of my early training came out of the Haley strategic model, the Washington School, as they sometimes call it. And of course, I studied MRI in that. I see myself in a broader sense. Like, I do find some of those ideas useful, particularly in understanding interactions and finding different places to intervene and to change the patterns that people have brought forth. But I think of systems as we all exist in large systems. Like, there's maybe our family of origin, but then we go outside of our immediate family and we're constantly working within systems. And of course, a system today could include children who are adopted, could mean friends, it could mean just those people who form the basic support system. So I don't limit myself in terms of thinking systemically in terms of, it just has to be the family, or I can't do therapy unless I'm working in a systemic way. I think I also have to think in terms of development across a lifespan. An individual goes through growth and development, and so does a family and a system, and so do relationships. And so I'm kind of thinking at multiple levels there, but I'm not a purist, and I don't adhere to any one particular approach, but I do think there's some ideas that exist from I would say earlier models like Minuchin structural therapy and the MRI and strategic that I think are useful, that I brought forth. And I do integrate narrative stuff and solution focus too. That's very important to me.
Right. You brought up something about families. It just kind of reminded me. My first wife, who's a clinical psychologist, she was doing a lot of work with foster families. And she couldn't understand why in a lot of the therapy interactions, with the system and things like that they weren't treating the foster family as a system. It's like they would think that the child, since it's not biologically there, and the child may only be there for a little while, that for some reason there wasn't a system. But it seems to me that any interaction, even if it's just for a few minutes, can be part of a system. I mean, what are your thoughts on that?
Well, I agree with that. I think that, as I said, I think we operate within a number of systems, and any system has to do with the people that are closest to that person and most influential. Our behavior can change based on how a friend is doing. And so I think we have to think in broader terms. And of course, if we want, not to get too tangential here, but if we really want a stronger society, I think we have to think about how our relationships interact and how, who we connect with can strengthen or actually, inhibit us from change. So I think, systems go even outside our immediate family. I work in a university for a good part of my each day, and I see kids who come away from home and their new system is, or I should say their expanded system involves their peers at school, and it's critically important to their success.
Mm-hmm. I totally agree. You had brought up something just in passing, and I know this is a big centerpiece of how you work. Could you tell me a little bit about, particularly when you're doing the work you put a lot of emphasis on what you refer to as strengths-based interventions. Could you tell me what kind of drew you to that kind of orientation?
Well, when I was getting my master's degree, the books that I was reading at the time, the traditional theories books, most of the models I was learning about generally were skewed towards pathology and what was wrong with people. And I found them appealing in some ways, but it was always trying to fix something. And I was really put off by that. When I came across Milton Erickson's work,
Mm-hmm.
I kind of stumbled on it. I thought, wow, this is different. And so I started looking at the different theorists at the time who were sort of purporting, what I thought was a resource-based approach, and that included solution-focused therapy and solution-oriented therapy and so on. So I wrote letters to all these people who were teaching at the time this stuff, and I got a single response. That single response was from Bill O'Hanlon, and I started studying with Bill. And what I learned from Bill, and Bill will use the term strengths or competency from time to time. He talked more about solutions, but for me, the basis of that has always been what the client brings to the table. And I found that not only much more satisfying personally, because it aligned with who I am as a person, but I believe it to be true. And I think since then, the research has caught up. The research says the clients are engineers of change. And I think we knew that anecdotally, but then we started really seeing in the research how when you do these randomized control trials, you find that the client's actions and the client's activity and involvement in therapy is really the biggest indicator of how successful they are. And so to me, it's not just evoking abilities and strengths and finding evidence of how the client has met challenges in the past and in the present, but it's also finding different ideas that fit with the client's sort of ways of operating within the world. So they're still learning. It's not just new, evoking abilities. It is a process, I think, of therapy is a process of engaging people in such a way that they learn new ideas and ways of doing things. So it's kind of a combination of those two things.
Absolutely. And for me as well, Bill O'Hanlon's been a big assistance to kind of help cement my focus. And other than being a burnout hippie, he's a great guy, so.
Yeah.
Well, which leads me to another thing that Bill and his mentor, Dr. Erickson, and quite a few other people talk about, which is expectancy and hope. And I know that that's a big component of your work, but sometimes I think therapists in general forget how important the idea of instilling this expectancy and hope is in the client, the family, or even, talking systemically, even in the system, to, I guess, create the conditions for change. How much do you focus on that?
It's a good question, Paul. I focus on it a lot. I think of expectancy and hope in a couple of different ways. One is my expectations going in and my sense of hope that I can really help this person. And I think we each as a clinician have to have confidence that what we're doing has potential to really help people to improve their lives. And so psychotherapy as a medium of change, I mean, there's nothing more discouraging for a client than having a therapist who doesn't believe in therapy. So we have to go in, no matter what is happening with that client, find something in their lives that's changeable. And the immediate problem may not change to a degree that everyone is satisfied, but there can be some kind of improvement. And I think it starts with the therapist's sense of, I'm here to help you, and I think there's something we can focus on. And then the second piece is the client's belief. And so in order to increase that sense of expectancy and hope, I have to align with them and work with them in a way that makes sense. So if I'm doing, if I'm using a particular intervention or strategy and it's just not a good fit, well, their sense of hope diminished because it feels to them like I'm trying to sell them a car they don't want to buy. And so I really want to understand their worldview, what their expectations are, what their hopes are, and try and align with that. And then hopefully expand from it if we can. But so I see expectancy and hope as working in two ways, my perspective and the client's perspective meeting. And I would also say that if, my expectation is, and this lines up with what the research says, is that most change happens earlier in therapy. And so I say to people, you should see some indication early on that our work together has been helpful to you in some way. And if not, you and I need to regroup and revisit our options. And I think that often creates some expectation for people rather than, I got to be in therapy for a year before I see any benefit.
Mm-hmm. Mm-hmm. One thing I kind of do, I don't tell clients this, but in my mind, I often think, well, what if this is the only time I see this person? Which, sometimes it is. And instead of having this, even though we make treatment plans over sessions and things, but just the back of my mind saying, since change does come earlier, what in this one session, if this is the only chance I get to be with this person, what can I do in this, 45-minute to 50-minute interaction? And if I can get past, the anxiety that I have to do, some magical thing, but just becoming more present and, just like you say, focusing on instilling some expectancy, because if the expectancy is that there's going to be change, but it's not always necessarily by something the therapist does, to me, that's more hopeful than, Obi-Wan, you're my only hope, Dr. Bertolino, can you help me? What are your thoughts on short-term, long-term therapy?
Well, first of all, I think you and I are sharing the same brain here.
I'm sorry on your part.
The whole concept of treating each session as an N of one that you really don't know you're going to have, whether you're going to have a second session or not, I think is very important. No one goes to their doctor saying and expects their doctor to say, hey, this is a 5-appointment, issue you have here. And, you're distressed when you go to your doctor. And if your doctor indicates in some way that, it's going to take us a while to connect and it's going to take us a while to, start to see progress, I think that's a risky message to give someone. And back to the whole idea of expectancy and hope, I think it can diminish hope quickly. I'm not promising the client that they're going to have a positive outcome, but I do want to focus in that one session as if it is the only one. And I want to figure out what I can do to maximize my effectiveness. Because as you said, there may not be a second session, even when people schedule a second session. So I'm thinking, what do we need to do minimally for this client to leave the session and feel like this was not only a good use of their time, but that something minimally is different for them? Now, in terms of brief and long-term therapy, I sort of feel like those, I'm hoping we are evolving past the whole idea of trying to categorize. But of course, I know people still think in those terms. What I've seen, I have my private practice. And so in my private practice, my average number of sessions is right around 4. In Youth in Need, which is a community-based organization in St. Louis area that I work for, I do consulting and clinical work, we have about 60 clinicians. And their average is 6 to 8 sessions. And this is a broad range of clients and so on. And again, we sort of see the same thing, that no matter what approach the therapist is using, we tend to see that average. Now, having said that, I do think that there are differences in how clients attend therapy. Some come for a couple sessions, maybe even one. They experience the change they want. They're back on track, and that's kind of it. Some clients, and I think we see more of this. In fact, at Youth in Need, I would say about 20% of our clients, this is what happens. They come in, and again, kind of relating to the family life cycle or development over time. What we see is they come for 3 to 5 sessions, or more, give or take, and they get back on track. And then we may see them 6 months later or a year later. It could be for the same problem has popped up again, or a completely different issue because they're further along in terms of their growth individually or in a relationship. And I like that approach, actually. You're not stigmatized for going to your doctor, once a year or something. Your doctor doesn't say, oh, you again. It's, in therapy, I think if we're truly wanting to take more of a perspective of promoting health and well-being, I think it makes good sense that when people feel uneasy or they're struggling with something, rather than waiting for it to become a huge crisis or big problem, we provide something that fits for them. And I think in and of itself then means that we see more what I would call serial brief therapy. And actually, this is a term Bill O'Hanlon's used, which is people come for a few sessions. Again, as I said, they finish and then we see them down the road. And I like that model. And I think we tend to see that. There are other variations, of course, with very chronic problems with people. We might see them a little more often or once a month. And I think so much of it depends on what their state of well-being is, what their functioning is, and so on. But generally speaking, therapy for me tends to be briefer.
Right. Right. Well, since you were discussing youth in need, that was one of the things I wanted to ask you about, because you've been working with this organization for a good while. Could you tell us a little bit about the focus of the organization, and maybe a little bit about, since you are dealing with young people, kind of how you approach working with young people?
So yeah, I mean, I started actually at Youth in Need in 1989. So I've been there 26 years. And as I said, I started as sort of a youth care worker in their emergency shelter. And then I worked as a therapist. I was a shelter director. I was vice president of clinical services, had a bunch of different hats. But Youth in Need is a organization that has about 450 employees and serve around 10,000 children, youth, and families a year. As I said, around 60 clinicians. Services range for birth and age of birth and all the way up through the age of 21. And most of these kids are high risk. Some of them are dealing with temporary situations. They're just trying to, work something out that's happening at home. Some of them have been from abusive families, substance abuse issues. It really runs the gamut in terms of the kids we see. We see a larger number of kids these days who are homeless, and 17, 18, 19-year-olds who it didn't work out at home for one reason or another and are trying to sort things out. We have a number of school-based therapists. We have foster care, early childhood programs, as I said, residential, outpatient, out-client counseling, so a variety of services. Our approach is to use, as we talked earlier, a strength-based approach. Everyone at the agency, whether you're doing maintenance or you're working as a teacher or you're a therapist, goes through, or even an accountant, you go through our strength-based 101 training, and we talk about the philosophy of the organization. So we're all sort of moving in the same direction in terms of a foundation for thinking about the people we work with and each other. Our perspective really very much is to help these young persons to increase their sense of well-being. It's important to raise their grades. It's important to be in school. It's important to find jobs. It's important to have a safe place to live. We're working on all of those things. What's equally as important is that their sense of how they feel about themselves, their sense of self-esteem and self-efficacy, and their interpersonal connections, those that are closest to them, and their sense of connection in school, that they're accomplishing something or that they're doing meaningful work or learning new skills. Those things, their perceptions of those things are also very important, because the youth who has improved grades but still feels down about himself, we're still worried about. So we're really thinking at two levels. What are the concrete, objective things we need to accomplish? And those are typically the things that led to therapy, and sort of improving well-being and functioning. And what we found in our research, because we track all of our outcomes every session, is that the kids who end up in the non-distressed range at the end of therapy, meaning by self-report, they're saying that I feel better about myself, my relationships, and my connection in the community and school and so on. Those kids that are in the non-distressed range tend to do better in the long run in terms of maintaining in school and work and so on, and having stronger support systems.
What do you find as a therapist your biggest challenges working with young people in general from a strength-based perspective compared to, let's say, individual adults?
That's a good question. I don't think I've ever thought about that. I would say that sometimes there's a misinterpretation of what strength-based means. It sounds fluffy. Sounds like you're only focusing on, what's working, or focusing on strengths and you're ignoring problems. And I don't think that that's a fair representation. In fact, I think it's an unfair interpretation. Strength-based means focusing on what is working and looking at the potential that people have, the examples in their past of how they've met challenges. And again, as I said, learning new ideas. And it means also having a good, solid understanding of what the problems are that they're facing and how distressed they are. And the strengths are a way of helping them to experience a positive change. Now, with young persons, what's interesting, my experiences has been young persons tend to be a little more flexible. Now, I don't want to work in painting too broad strokes here, but because there are exceptions. But young people come in with a sense of, the world can change and things can be different, and sometimes they just haven't had the opportunity, or they've, if they said they've been dealt a poor hand, and it's a matter of playing it well. But when we start talking about adults, I think occasionally, just because they've lived longer lives and had more experiences and maybe greater challenges, that there can be a sense of, oh, well, it's just not going to get any better, and why try, and that kind of thing. And I to connect something that you asked about earlier, that sense of hope and expectancy, sometimes I feel like we are holding the hope for them until they can regain it themselves. So the difference, I would say, is that I think there's a greater sensitivity to the perspective of adults in terms of not trying to get them to jump tracks and think differently about their lives, but to align with them, have a deep understanding of what they're facing and how difficult it's been for them. And then saying, how have you, in the midst of all of this, managed to keep going and keep your family together, or, keep your eyes on the road when it would have been easy to give up? I think there's a segue into that, but I don't think I can do that, or anyone can really do that effectively without a deep understanding of the suffering that people are experiencing. And so I think that would be the big difference, is adults maybe can be a little slower to come around with that just because they've faced more challenges than young persons. But again, that is painting in broad strokes.
Right. Well, do you? I know you've been involved with kind of the what we are calling now the feedback informed treatment. You've worked. I'm assuming you've worked with Scott Miller with kind of a lot of assessing outcomes in therapy, and Scott's done a lot of great work. And how much, as the session's going on, are you in your mind mentally, and maybe even literally, where you're scoring and writing down the feedback you're getting, as far as at the end of the session, did this meet your needs, or is that something that's a part of your outlook when working with individuals and families?
Yeah, it's a big part of what I do. I met Scott in 1998, somewhere around there, maybe a little earlier, 97. And so I've started seen the incarnations of the change over time. And so when the feedback stuff started to really catch hold, we integrated it immediately at Youth in Need right around 2004. And voluntarily, not because someone told us we had to. And part of the reason was that we really wanted greater evidence that what we were doing was working. In community-based care, and particularly in the non-for-profit world, everybody says we're providing great services for people in great need. And of course, that's true. But in a slew of organizations that are doing the same kind of work, how do you really tease out that information that tells you that this organization is truly doing work that produces reliable and valid change in the aggregate? And so we started to do that in 2004 and formalized it over time to the point that every therapist in every session does track their change. We built a software system called Imagine that the therapists use. It tracks all of their data. It runs the outcome measures. It produces feedback alerts, you're on track, off track, and gives suggestions about things to do. Doesn't tell the therapist what to do. It just offers ideas that they can then discuss with their clients. Every therapist knows whether their client is on track, off track, whether they're getting worse, whether they're improving. They also know their effect size, which means they know their effectiveness as compared to other therapists. And they know how many clients are discharging in the non-distressed range and the distressed range. With that kind of feedback, we can help therapists to get better. But most importantly, we can respond very quickly to our clients, and making sure that, if something's not working, we're aware of it sooner rather than later. And in the same token, if they have improved to a non-clinical range and seem to be sustaining that, we don't keep them in services any longer than they need to. So it's a huge part of our work. I would say the feedback is only one part, because you can get feedback and it doesn't necessarily change anything. You have to train people how to use feedback and be responsive. But yes, it's critically important to what we do.
Okay. How, if somebody's listening right now, how would you alleviate their concern as a therapist? Because, we're here tracking with the computer and measuring, and some people may have visions of, open the pod doors, how, where it's we're losing the humanity of therapy with all this assessment, but that's not really what you're doing, is it?
No, it's not. And I understand those concerns. I've heard them myself, and I think early on I would have shared some of the same ones. I certainly, respect how therapists work, and they develop their own styles. There's, of course, risk in that, as, the researcher from South Florida, Kay Anders Erickson, says, the enemy of proficiency is automaticity. We
Right.
step in and we start doing the same things over and over again. And unfortunately, some of those routines get in the way of actually being effective, because the client gets lost in that process. And I think what the feedback does is it brings it back front and center. Here's what we say to our clients when they come in, and this is what I say in my clients in private practice. We say there's two things that are very important, we think, to our work together. The first is we want to know whether or not our work together is beneficial to you, whether you're feeling like things are improving or not improving, so that we can work together to make sure that you're getting what you came for. That's the first thing. The second thing is we want to know whether the way we're working together is a good fit for you or not. And again, if there's something that's not working for you, we're spending too much time on something, or the approach I'm using isn't a good fit, or you don't feel heard and understood, it'd be helpful for me to know that. It's kind of my professional development, so that I can again make changes, and you will be more satisfied with the way we're approaching things. And the way that we track these is we do a very brief measure at the beginning of the session and one at the end, and each will take less than a minute to do. And we'll do them right on the computer here, and you and I will talk about the results. And then I'll also check in with you periodically through the session. Is that okay with you? And once therapists get acclimated to that idea, and by the way, new therapists have no issue with this whatsoever. They learn it. They go, wow, this is amazing. I wish my doctor would do this. And your doctor doesn't say, hey, let's try this and then I'll see you in 5 months.
Right.
They want to know whether it's working or not. So it's the therapists sometimes who've been around for a while sometimes struggle because they've fallen more into their routines, and they feel, as you were kind of saying, it can feel like an impediment or a disruption. And but again, I think we've been successful in working around that by talking about how you do this, and also by exploring people's concerns. I think you have to address those up front. And we spend a lot of training on this, so that's my experience. But I will say this, Paul, and I think this is important. When people get training in what we call FIT, feedback-informed treatment, or using any methods, for an organization to be successful, it's not just the clinicians that have to take a look at their practices. They have to have an administrative sort of group of persons that are also supporting this. It can't be top down. The administrators say, you do this and just do it because we say so, and the therapists have no feedback in that. And it can't just be the therapist saying we're going to do this and the administrators not giving the support. It's both working together. And I think that is the recipe for success. But I do understand those concerns, and I think we have to talk about them further. But our experience has been that we can work with those things.
And it's my understanding that, of course, this isn't telling anybody, that they need to change their theoretical orientations, the things that have worked for them in the past. It's merely getting feedback. The way we used to do, I'm sure you did with the marriage and family background, the reflecting teams. You go in and go, okay, what am I missing? And how can it be better? And it just sounds like this is a a different way to maybe an updated way of the traditional, systemic reflecting teams.
Yeah, I mean, I think it's another form of feedback. It still tends to keep the feedback within the system. And the reflecting teams are wonderful. I mean, we still use those, as a way of getting sort of external feedback. A closed system needs new ideas. And this way also works within the system to say, wait a minute, let's take a step back and let's just see how things are going here, kind of taking the pulse. Or keeping your finger on the pulse or taking the temperature, however you want to frame it. But it keeps the client actively part of the process. And, what we're finding is that if you start that from the beginning of therapy, then the expectation on the part of the client becomes one of, we're going to talk about this, whether it's working. And some of the mystical elements of, the therapist is going to come in and wave a wand and change is going to occur and I should walk out and just feel better. I think that takes some of that off the table because, again, there is much more of an ongoing sort of review of how things are going. And again, the client expects that. When you start tracking outcomes in the middle of therapy, like you're 5 sessions in, it can feel weird for clients. Like, why now? Why are we doing this now? We suggest that it started at the beginning. But yes, it is another form of feedback and perhaps a cousin to reflecting teams.
Yeah. One thing when you're talking about the interaction with the client and getting the feedback and then, kind of taking away the mystical elements. And granted, there may be a time that comes in handy to where the therapist is the magician, so I don't want to generalize here. But I remember Jay Haley's, and again, love me some Jay Haley, but the whole emphasis on the power where you pretty much tell your client's family, whoever you're working with, okay, you obviously can't handle this. You've screwed up the situation. I mean, you say it in a nicer way. So I'm going to give you directives on how to untangle. What are your thoughts about, being directive with this kind of feedback?
Yeah. Well, so again, I think so much of how you approach clients depends on the relationship itself. There are clients who want you to be more directive. And there are clients who that doesn't work for them. And the way because so often we are incorrect in terms of our perceptions of the relationship. The way we think it went is very different than the client's experience of it. So I think if we're in tune to the client, I have no issue with being more direct. And I wouldn't say I would be as direct as Haley would have been to say, you obviously can't handle this situation, so here's what I need you to do. I would modify that, and I learned that approach, and I did use it for quite a while, particularly early in my career. What I found was if I actually felt that it was useful to have a well-developed sort of directive for a client, I would actually talk with them more about the logic behind it. Now, if I'm doing paradox or something, that will be different, but I don't use that so often these days. Maybe a little bit in hypnosis, but not as often just in straightforward non-hypnotic stuff. But I would involve the client a lot more in the process, because the thing is, the client, when they go make a change, I don't want them to sort of develop a sense of dependency that the reason the change occurred is because, again, there was this magical element. I view myself as a facilitator of change. And sometimes change occurs and we just have no idea why, and that's okay. There is a mystical element. I'm all right with that. But the bulk of change, if it's going to last, in my experience, has to be tied to the client's sense of locus of control, their sense of I did something to have this change occur. So if I'm going to use a directive, a front door directive or something, I'm more likely to engage the client in the process and talking about the logic behind it, so that, again, they're more likely to follow through. And then when the change does occur, they're more likely to assign that the reason of the change to their efforts rather than mine. So I don't dismiss any of that stuff. I think it's very useful, but Haley developed those ideas in a particular context, as did most of the therapists, and I have great respect for that. I would just talk about it differently these days.
Yeah. I also find that giving the directives, either it needs to be so, I mean, just my perspective, it either needs to be so ridiculous that the client does indeed kind of feel that he or she, oh, I did it, so I can do this, or it needs to be so clear that they know that they again did it. Because I think if they feel that it's a manipulation, even a good manipulation by the therapist, well, they're just going to keep showing up every time they have a problem.
Right.
Okay, give me a new directive, boss. I can't handle my own problems. And
Right.
I think sometimes the older generation, now granted, guys like Erickson were that was the era where he was a medical doctor and everyone that generation just did what the doctor says. But it kind of makes some people, I mean, in our day now, in my opinion, kind of treats them kind of infantile. You just come to me with your problems and I'll solve them.
Yeah, I agree with that. I think it downplays the client's abilities to actually make changes in their lives. I think part of the there's some real disagreement in this, but I really think a critically important thing for therapists is to sort out their philosophical perspective. In other words, where are you coming from in general before you ever start talking about a model or a template for change? How do you think about people? Do you think that people have the capacity to change? Do you think that change is even possible? Those kinds of things drive therapy for me. And to me, if in the end, if you look back to that position that a therapist has to take for themselves, then that will indicate a lot about the questions that are asked, the interventions that are used, and again, how people engage clients. And I've had disagreements with people that say that doesn't matter. You just pragmatically go in and ask these questions, and this is what you do, and it works or it doesn't work. And I just could not disagree more with that. Therapy is a human endeavor. And I think our perspectives shine through in a big way. And I think that that's kind of the starting point for me is that sometimes I will say to people things like, well, from everything I've heard, I don't see any reason or any evidence that you're really willing to put forth an effort to change things here. I will say things like that, which are sort of why don't you just continue what you're doing? And of course they'll take exception to it. And that to me is strategic. Yes. I wouldn't randomly say it, but I would say it in a particular context. Also, if I knew that the relationship was such with the client that I wouldn't be saying it in a disrespectful way or an inflammatory way, it would be an observation. And we would go from there. But I wouldn't use it necessarily as just going in and I'm going to, try and direct this person to, try and manipulate them in some way. I would be purposeful. It would be a direct observation and try and get them to see that position, because looking at a situation from a different point of view can be very, very helpful for our clients. It's helpful for us. So if we achieve that and they go, oh, you know what, you're right, we've been talking about this for 3 weeks and I haven't done anything. Well, then it plays a role. But I think it starts with perspective. And whatever I do, I hope to do it out of respect and care for the client, not just because it was an ingenious maneuver.
Right. I find that and this is, I'm beginning to believe is human nature, that we operate so much mentally out of dichotomy. So, you go to any basic psychology or psychotherapy textbook, you got, okay, over here are the directive therapies and over here are the indirect therapies. And it's like already we've set up a dichotomy, so the person who wants to be directly indirect or indirectly direct, it gets a bit confusing, I think, for new therapists.
Yeah, I agree. Yeah, I would say that what I would advise therapists to choose their approach based more on the relationship with the client. And, sometimes you're more direct, sometimes you're less direct, but I would agree that those dichotomies only serve therapists. I don't really think that they serve clients in any beneficial way.
Well, that's the quote of the whole conversation, I think. I couldn't agree more. Well, before we wrap it up, I wonder if you could let everybody know who interested in kind of the things you're talking about, the best way they can get in touch with you, find your books, attend your trainings. If you feel free to give out that info.
Absolutely. Thank you. So my website is just bobbertolino.com. And I can be reached through email at bertolinob@cs.com, or just Google me. You can find me at Maryville University in St. Louis. You can find me at Youth in Need in St. Charles, Missouri. So typically a little search will find me. I'm on LinkedIn and those kinds of things as well. And I'm always happy to provide support for people if they need that. And I'm around from time, typically once on the road, about once a month, teaching workshops, and kind of have an agreement with my family to not travel much more than that. But so I'm always happy to hear from people.
Okay. And I want to just let everyone know who's listening. I've been attended some of Bob's trainings. It's really great stuff. This past December, we were both presenting at the Ericksonian Congress, and I got to sneak away and attend your session. I just really enjoyed it, and I enjoyed your insights. Particularly, I think you were giving a lot of good case studies about working with young people, which gave me some good ideas. So I encourage everybody to definitely check you out.
Thank you, Paul.
Yeah, sure thing. Well, thank you for being here, my friend.
You're welcome. Thanks for the opportunity, Paul.
Good thing.
Thank you for listening to Potential Not Pathology with Dr. Paul J. Leslie. If you enjoyed the show, check out our website at potentialnotpathology.com, where you will find programs and articles showcasing unique and creative therapeutic applications.